is moderated by Dr. Dominic Akativa. So this is the outline of the presentation. So we start with a brief anatomy of the thyroid gland. The thyroid gland is a butterfly shaped consisting of two lobes that is connected in the middle by an isthmus. It is found in the anterior neck just below the laryngeal prominence. So definition of hyperthyroidism. Hyperthyroidism refers to overactivity of the thyroid gland that leads to excessive secretion of thyroid hormones. And these higher levels of thyroid hormones leads to hypermetabolic condition of thyrotoxicosis. So the term thyrotoxicosis and hyperthyroidism are often used interchangeably, but they actually have different meanings. So just like we have looked at the hyperthyroidism, thyrotoxicosis, on the other hand, is a clinical effect of an unbound thyroid hormone with or without increase in thyroid hormone synthesis. So an example can be seen in the case of excessive intake of thyroid hormone medications like levothyroxine. So with this, there will be increase in the levels of thyroid hormone, but not necessarily from the thyroid hormone synthesis. Epidemiology. Hyperthyroidism is more common in women than in men. It has a ratio of 5:1. It's also more common in smokers. The overall prevalence of hyperthyroidism, which is approximately 1.3%, actually increases to 4 to 5% in older women. Causes of hyperthyroidism. The first cause we look at is Graves' disease. Graves' disease is an autoimmune disorder that is characterized by a variety of circulating antibodies, the most important one being the thyroid stimulating antibody. This acts as a thyroid stimulating hormone receptor agonist. So it binds to the thyroid stimulating hormone and in turn leads to increased synthesis of thyroid hormone. It's actually the most common cause of hyperthyroidism, causing approximately 50 to 60% of cases. And it is characterized by the presence of thyrotoxic signs and symptoms, together with evidence of ophthalmopathy or dermopathy, or sometimes or. The second cause we look at is subacute thyroiditis. This is a self-limiting condition, most of the times caused by viral infections, and it is associated with a triphasic clinical course. So usually there's a phase of hyperthyroidism, followed by a phase of hypothyroidism, and return to normal thyroid function. It has three subtypes. So the first subtype is a subacute granulomatous thyroiditis. This is also known as a subacute painful or decrevent thyroiditis. The second subtype is a subacute lymphocytic thyroiditis, which is also known as a subacute painless thyroiditis. The third subtype is a subacute postpartum thyroiditis. Actually, all these three subtypes have different causes, but they all follow the same triphasic clinical course I mentioned earlier. And it is very important we recognize this because most of the times it's self-limiting and might not need any specific form of treatment. The next cause is toxic multinodular goiter. This accounts for 15 to 20% of cases. This is also known as the plumber disease. So we also have toxic adenoma. So with this, there's single hyperfunctioning follicular thyroid adenoma, and this accounts for approximately 3 to 5% of the cases. The other cause is thyrotropin secreting tumor, also known as a pituitary adenoma. This actually secretes thyroid stimulating hormone and in turn can lead to the synthesis of thyroid hormone. The last but not the least is amiodarone-induced thyroiditis. This usually is seen in patients who are on amiodarone. So pathophysiology. The synthesis of thyroid hormone is controlled by a complex mechanism that involves both inhibitory and stimulating factors. So it actually starts from the hypothalamus. The hypothalamus secretes thyrotropin releasing hormone. This acts on the pituitary gland, which tend to cause it to secrete the thyroid stimulating hormone, which acts on the thyroid gland and eventually leading to the formation of thyroid hormones. Now, elevated levels of the thyroid hormone would cause a negative feedback mechanism on the hypothalamus. This tends to inhibit the secretion of a thyrotropin releasing hormone, eventually leading to inhibition of thyroid stimulating hormone, and the cycle goes on. Thyroid hormone synthesis proper. Dietary inorganic iodide is a very key component here. So dietary inorganic iodide is transported into the cell by an iodide transporter. So this is converted into iodine. The iodine then binds to thyroglobulin by an enzyme known as the thyroid peroxidase, and through a process known as organification, it combines with tyrosine to form monoiodotyrosine or diiodotyrosine. These then couple to form T3, that's a triiodothyronine, and T4, that's a tyrosine. So these thyroid hormones are then released into circulation, but usually more of T4 is formed than T3. And most of the times, there's peripheral conversion of T4 into T3. You should also know that T3 is more biologically active than T4. And when they are released into circulation, they bound to other proteins. And most of the time, the unbound portion causes the clinical effects. WHO grading system for goiter. So it grades this into three. So the grade 0, with this, the goiter is not usually palpable or visible, even when the neck is extended. For grade 1, we have 1A and 1B. 1A, the goiter is detected on palpation. 1B, the goiter is palpable and visible when the neck is extended. For grade 2, the goiter is visible when the neck is even in normal position. And for grade 3, we have a large goiter, which is even visible from a distance. This grading system is actually very important because it can serve as a factor to consider in choosing a definitive management for the patient. Signs and symptoms of hyperthyroidism. Hyperthyroidism tends to affect almost all systems, and patients usually present with vast symptoms that cut across almost all systems as well. So younger patients tend to exhibit symptoms of sympathetic activation, such as anxiety, hyperactivity, and tremors, while the older patients would have more cardiovascular symptoms like dyspnea and atrial fibrillation. We should also note that the clinical manifestation of thyroid toxicosis do not always correlate with the extent of biochemical abnormality. So some of the symptoms include, you have nervousness, anxiety, excessive sweating, heat intolerance, hyperactivity, palpitations, weight loss despite increased or normal appetite. Others come with insomnia, weakness, and increased frequency of bowel movements. Some patients can also come in with eye symptoms such as tearing, photophobia, eye pain, protrusion, and visual loss sometimes. Some can also come in with compressive symptoms like neck fullness, dysphagia, choking, or dyspnea. The compressive symptoms is usually particular in those with larger goiter, and most of the times, these patients would actually need ICU management for intubation. These are some of the signs that can be picked up on examination. Actually, these are organized based on anatomic regions. So with the skin can be warm, moist, or fine. There could also be pretibial myxedema. That's a non-pitting edema in the pretibial regions. And this is usually due to deposition of glycosaminoglycans. And most of the times it has the orange peel It resembles an orange peel in appearance and texture. With the eye, there could be proptosis, that's forward displacement of the eye. It could also be lid retraction and periorbital edema. The periorbital edema is as a result of infiltration of lymphocytic cells in the periorbital region. On examination of the neck, the thyroid could either be palpated or not. And if in the event is palpated, you could either palpate a single nodule, multiple nodules, or no nodule at all. On the chest, there could be gynecomastia in males. So you could also have tachypnea, tachycardia, hyperactive precordium. With the abdomen, there could be hyperactive bowel sounds. For extremities, I've talked about pretibial myxedema. This can be found in the extremities as well. They could also be fine and bilateral tremors on neurological examination. So this is just a picture of the pretibial myxedema, and that's ophthalmopathy. We have periorbital edema with proptosis. We also have injection and lid retraction as well here. Investigations. The first test you want to do in hyperthyroidism is a thyroid function test. This usually measures the levels of thyroid stimulating hormone and the thyroid hormone levels, usually the free T3 and free T4. And the thyroid function test can create a picture of either overt hyperthyroidism, T3 toxicosis, T4 toxicosis, or subclinical hyperthyroidism. With the overt hyperthyroidism, there's a decrease in thyroid stimulating hormone levels with elevated thyroid hormone levels. With T3 toxicosis, we have an increase in FT3 than FT4. And with the TSH, it could either be low or just at the lower limit. For T4 toxicosis, the FT4 is usually higher than FT3. And with subclinical hyperthyroidism, we have a decrease in TSH level with normal levels of FT3 and FT4. And most of the time, this is seen in patients who are undergoing treatments. The other test you want to do is thyroid autoantibodies, especially the antithyroid peroxidase antibody, which is usually significantly elevated in Graves' disease and usually low or absent in toxic multinodular goiter or toxic adenoma. We also have the thyroid stimulating hormone receptor antibody, which may also be elevated in Graves. You also want to do an ultrasound of the thyroid. This distinguishes between cystic and solid nodules. The other investigation we want to do is a scintigraphy, also known as the radioactive iodine uptake. So this uses either iodine 123 or technetium 99M, and it measures the degree and pattern. So the degree and pattern of the isotope uptake can help indicate the type of thyroid disorder. You also want to do a full blood count and a liver function test. Usually these tests serve as the baseline. So this is a diagram of scintigraphy. It shows the degree and pattern of the isotope uptake by the various conditions. So this is a normal thyroid gland. So with Graves' disease, there's increased isotope uptake and it is usually diffuse. For toxic multinodular goiter, we have increased uptake in the regions of the nodules, and we also have other regions of normal uptake. For toxic adenoma, we have a solitary and well-defined region of increased radioisotope uptake, and this is usually the area of the nodule. Management. Just like any other condition, management usually comprises of history, physical examination, investigations, and treatment. So with the history, you want to do a very detailed history comprising almost all parts of the history, such as the past medical history, social history, family history, because this can actually lead you to getting a cause of the hyperthyroidism. For instance, a past medical history or a family history of autoimmune condition can tailor you towards more of an autoimmune cause of the hyperthyroidism. With physical examination, you do a very thorough examination from head to toe, as I mentioned in the science earlier on. Then investigations, which we have just talked about. Treatment of hyperthyroidism. The treatment of we have to employ a multidisciplinary approach in the treatment of hyperthyroidism. So usually we involve the physician, an endocrinologist. In most instances, ophthalmologists as well as a dermatologist would be needed in the management. And treatment is usually into two. We have the symptom relief and the definitive treatment of hyperthyroidism, which could either be with the use of antithyroid pharmacotherapy, a radioactive iodine, that's iodine 131, or thyroidectomy. For symptom relief, most of the neurologic and cardiovascular symptoms are relieved by beta blocker therapy. However, this therapy is contraindicated in patients with a significant history of asthma because this can actually cause bronchospasms. So in these patients, calcium channel blockers can be used to replace. And these therapies should be tapered and stopped once thyroid function comes within normal range. As part of the symptom relief, if the patient presents with ophthalmopathy, then you need to seek an ophthalmology consultation for him or her. Less serious ophthalmologic symptoms like photophobia, tearing, or irritation can be treated with tight-fitting glasses and saline eye drops. The glasses should be worn almost all the time, especially when patient is outside. For dermopathy, there's no effective treatment. However, application of high-potency topical steroid could be of benefit. And with this, you need to involve the dermatologist as well. The definitive treatment. So the first form we'll look at is antithyroid pharmacotherapy. Antithyroid drugs such as carbimazole, metimazole, and propylthiouracil have been used for hyperthyroidism. These inhibit the formation and coupling of iodothyroxines in the thyroglobulin. A second action of propylthiouracil is the inhibition of conversion of T4 to T3. So except in thyroid storm, propylthiouracil is usually considered a second-line drug therapy, and it is reserved for patients who are allergic or intolerant to metimazole, and in women who are in the first trimester of pregnancy or women planning to become pregnant. So with the metimazole, you can give like 5 to 30 milligrams per day. This is divided 8 hourly. But sometimes you can go as high as 60 milligrams a day based on the clinical picture of the patient and also under specialist supervision. For carbimazole, you can do 15 to 40 milligrams per day. This should be continued until the patient becomes euthyroid. Then the dose can be reduced to 5 to 15 milligrams daily. And this dose is usually tapered down. Therapy can usually be extended for like 12 to 18 months. The other form of anti-thyroid pharmacotherapy we look at is iodine or the use of iodinated contrast agents. The exact mechanism of this is not clearly understood, but some studies suggest that these agents tend to inhibit iodine organification in the thyroglobulin, and with this, it tends to cause a decrease in thyroid hormone synthesis. Side effects of anti-thyroid medications. Antithyroid medication comes with their side effects, and for this reason, it is a responsibility of the clinician to adequately educate the patient on the side effects and the need to seek medical attention if in the event these side effects tend to occur. So common side effects are fever, rash, urticaria. However, more serious side effects include agranulocytosis, aplastic anemia, hepatitis, polyarthritis, and lupus-like vasculitis. So for agranulocytosis, the patient needs to seek medical attention if he or she starts to experience sore throats with fever. The other form of definitive treatment is radioactive iodine therapy. This therapy is actually based on the assumption that the thyroid gland is the only organ in the body that absorbs iodine. So radioactive iodine is usually given to the patient, and this radioactive iodine is absorbed by the thyroid gland and in turn causes destruction of the thyroid tissues. The last definitive management is surgery, and this can either be total or subtotal thyroidectomy. And surgery is usually, before surgery is done, the patient must be rendered euthyroid with the use of the antithyroid pharmacotherapy. Surgery is usually done for patients with the compressive symptoms I mentioned earlier on, and it comes with its complications. So we can have hypoparathyroidism and paralysis of the vocal cords from the surgery. Complications of hyperthyroidism. So first is a thyroid storm, also known as a thyrotoxic crisis. This is a life-threatening health condition. Patients usually present with excessive vomiting, excessive sweating, fever. Some can also come in with seizures and altered mental status. And most of the times, their temperature, heart rate, blood pressure is usually elevated to very high levels. This is actually a medical emergency and should be treated as such. The other complication is atrial fibrillation. This increases the patient's risk of developing stroke and other cardiovascular complications as well. Then other complication is loss of vision. Just like I mentioned earlier on, most of the times they have periorbital edema, and excessive edema can lead to compression of the optic nerve, and this can lead to loss of vision. Some patients also tend to have osteoporosis. Differential diagnosis of hyperthyroidism. The causes I mentioned, all the causes I mentioned earlier on can actually be differential diagnosis for hyperthyroidism, but others include, we have factitious hyperthyroidism. So with this hyperthyroidism, that is due to intentional intake of thyroid hormone medications. And studies actually shows that this is usually more common in medical personnel since they tend to have easy access to these medications. And most of the times they take it for other reasons like weight loss, energy boost, and so on. The other differential is trauma ovary. This is actually a rare ovarian tumor that contains thyroid tissue and most of the times lead to hyperthyroidism. So these are my references. Thank you.
Great job done. Thank you, Dr. Rahima, for the brilliant presentation. And this was done in less than 30 minutes. So allows us a good time to have a discourse around it. I would wish to invite my very own professor of endocrinology, Dr. Morgan, to give us some insights, and then I open the floor for any questions. As well, like I made mention of at the beginning of the presentation, you could still use the chat box if you don't intend to speak. Otherwise, you can electronically raise up your hand. I would unmute you, or I would allow you to unmute yourself and then go ahead with your comments. Dr. Morgan.
Dr. Katsiba, thank you very much for the forum that you have provided for us all to share some knowledge and on what we know. I think Dr. I didn't really get any more. She's done a very good presentation. Rahima, okay. Yeah, she's done a very good presentation. It has summarized essentially what hyperthyroidism is about. So, I mean, hyperthyroidism, like you said, is essentially when the thyroid hormone levels are elevated. And we say that it can either be primary or secondary. Primary when the cause of the thyroid stimulation is coming from the thyroid gland itself. And then secondary if it's coming from, she mentioned the, the TSH from the pituitary. And then also from the hypothalamus, you can say that's a tertiary. So essentially, what the thyroid hormone does is to increase our metabolism and increase our activity. So you realize that everything is, I like to say everything is gone haywire. Everything is fast, more than it should be. So if it's the heart is beating faster than it should be. If it's the abdomen, the diarrhea, you're going to more stools than you should normally pass. If it is sweating, so everything is exaggerated that you'd have. And then to control it, she mentioned about the drugs that you'd want to use. So the anti-thyroid medication, there's also the option of surgery, and then there's also the option of the radioiodine therapy. And then I like the fact that she mentioned that before you attempt either the radioiodine or the surgery, you want to render the person euthyroid. Otherwise, you'd risk precipitating a thyroid storm or a thyroid crisis, which she mentioned. So I think that's just a summary of everything that she said. That was a very good presentation.
Great. Thank you very much, Dr. Morgan. And I see a question from Dr. Joel asking about the role of thyroid hormones in mood and psychotic symptoms. Definitely, that's one of the manifestations, I'm sure, of hyperthyroidism or thyroidoscosis that we need not to overlook. The personality changes, psychosis and agitation, and even sometimes insomnia and all of that comes, as well as the emotional liability. Dr. Morgan, do you have any additions to that?
Yeah, sorry, I was muted. So I was saying that typically you would use it if the cause of the mood disorder is attributable to, say, hypothyroidism. Using it alone to elevate in people with mood disorders, I haven't really come across that. But I know that in hypothyroidism, when they have the slowed mentation, when they are depressed, yes, when you give them the thyroid hormones, it can help in the recovery process. But just giving it isolatedly in someone who doesn't have a thyroid problem, I haven't really come across that yet. Maybe I have to research more on that.
Great. I thought it was more of, he was asking about the clinical manifestations in terms of neuropsychiatry manifestations. Other than that, like the role of use of the thyroid hormones in mood and psychotic symptoms, I'm not so clear. Dr. Joel, he's a mental health specialist. If you can probably, you can mute yourself and then make it clearer so that then we go ahead.
Hi, good evening. Thank you very much for this platform. I hope you can hear me.
Yes, please.
Yes.
Okay. So as you know, I'm always biased towards psychiatry. So whenever you are having your programs, I'm always looking for the psychiatric angle to help make some contributions.
That's very important, is that not so?
Yes. So there is a significant correlation Can you hear me?
Yes, we can hear you now.
Okay. All right. Sorry about that. So mood disorders have thyroid disorders. And so you find that in some cases, the presentation might look like a typical depression, a typical mania, or a typical psychosis. But this is not functional. This could probably be as a result of a thyroid abnormality. So people who would have low thyroid levels and hypothyroid states can present with cases of severe depression, and then also florid psychosis with delusions. And you might think that this person has a psychotic depression. What we've realized is that with most people with depression, when you even do a thyroid function, you might find that a few of them are hypothyroid. And those that are resistant to treatment with antidepressants, augmenting them with thyroid supplementation helps to improve their recovery. So in the brain, there are receptors for T3, T4, and then this also, especially in the amygdala and other deep brain structures. And these areas, these thyroid hormones also tend to modulate the activities of some of the other neurotransmitters that are responsible for regulating mood and perception in the person. So it is not every mood disorder that you would find coming to see you that would typically be functional. So when we come across patients who have depression or psychosis or mania, as part of our assessment, we should look out for the clinical signs. Most of the time, you may pick up a few of the clinical symptoms of either a hypothyroid or a hyperthyroid state. And when you do your thyroid function, you may be able to help these people. So once you correct the thyroid problem, then most of the psychotic or mood symptoms will resolve. Thank you.
Great. Thank you very much for those wonderful insights. Going through the chat box, I see okay, so from Sani, wonderful presentation. He's asking why is women 4 times more of contracting hyperthyroidism than males? Okay, essentially he's asking why hyperthyroidism is more common in females than males. Dr. Rai, do you have an answer to that?
Well, actually, no, I did not come across.
Yeah, so so especially with Graves' disease, most of the issues about autoimmune causes or autoimmune diseases are more prevalent in females, like you have with systemic lupus erythematosus and all of that. Graves' disease essentially is an autoimmune condition and probably accounts for why you tend to have the feminine or the more prevalence in females than males. As for the definitive reason, I can't say myself as well. Dr. Morgan, do you have any response to that?
Yeah, I think my response is more of a joke that they said women, we like fighting a lot. So even in our own bodies, things are always fighting against each other. So that is why autoimmune diseases are more common in women than in men, because we like fighting. So everything, things are always fighting. That's just a jovial. But I mean, as to why autoimmune disease typically occur in women, we haven't really found out why as yet. But we know that, as Dr. Katiba said, autoimmune diseases are more prevalent in females than in males. So maybe if we become calm like the guys, our troubles will end.
Okay, so he follows it up by asking whether you can have reoccurrence of the hyperthyroidism following thyroidectomy. I think that's a yes to that as well. You do.
Yeah, because I think typically they do.
Yes.
Yeah, because typically they do like a subtotal.
Subtotal, yeah. Please go ahead, Dr. Morgan.
Yeah, I was saying that typically they don't do a total thyroidectomy for hyperthyroid. It's usually a subtotal thyroidectomy that is done. And so the little tissue that is left in rare cases can become overactive. And so it's possible. Remember that in medicine, we never say never for anything. Nothing is ever 100%.
Yeah. Okay. And I think Fam Salom is saying that you did a brilliant presentation, Rahima. He's asking whether there are treatment modalities in pregnancy. I think she addressed that regards the trimester of the pregnancy. But Dr. Rahima, would you want to go over that for us?
Okay. So just like I mentioned earlier on, we use either carbimazole, metimazole, or propylthyroxine, but in pregnancy, they often use the propylthyroxine because metimazole tend to have teratogenic effect in the first trimester of pregnancy.
Great. So obviously the amount the tyranamide, so the more effective ones are of course the metimazole or carbimazole, depending on where you are. I think we follow the British, so we use carbimazole, which is a prodrug. Actually, carbimazole is metabolized to metimazole as a metabolite and the active component. And they are, of course, more effective than propylthyroxine. But like she rightly said, in the first trimester of pregnancy, because of organogenesis and the risk of having issues with organogenesis and the use of the metimazole or carbimazole, you prefer to use the propylthyroxine. But after the first trimester, obviously you go ahead with either carbimazole or metimazole by way of the medical management. The thing that we need to push out again is the other definitive forms, i.e. the thyroidectomy and then the use of the radioactive iodine or radioiodine. Obviously, the pregnancy, you can't use that. And again, with regards to operating a pregnant woman with hyperthyroidism is something that most surgeons would of course not do. So it virtually leaves us with the medical management, or the patient then is out of that, and then we can go ahead with the definitive management. Dr. Morgan, I don't know if you have more to add to it.
Yeah, what I wanted to add was that in diagnosing pregnant women with hyperthyroidism, we usually have to be very cautious because we know that the beta HCG has a component that is similar in chemical terms to the TSH. And so in pregnant women, you may find that they are hyperthyroid, particularly if it's twin gestation, and also in women who are experiencing hyperemesis gravidarum. And so they usually have trimester cutoff values for pregnant women. And so in diagnosing a woman with hyperthyroidism who is pregnant, make sure you eliminate all those possibilities and you have a look at the trimester specific values. Otherwise, we may wrongly diagnose them as hyperthyroid when in actual fact they are not. And then again, in women who also have choriocarcinoma, yes, they may also come with gestational trophoblastic disease. Yes, they may also come with signs of hyperthyroidism that sometimes we may actually have to treat again because of the effect of the HCG on the it's being analogous to the TSH receptor. So we should be careful.
Great. Right. Thank you very much. I don't see any other question in the chat box. Please take note that I just put up a link. He has 4 questions. I think in less than 30 seconds, you could evaluate this presentation. Kindly click on the link and then give us a yes or no response to it to improve upon our subsequent presentations. Thank you. I don't see any hand up as well. In closing, I just want to stress the fact that hyperthyroidism is real, and sometimes we may have to be careful with, especially patients who come in with palpitations and easy fatigue with loss of weight despite an increased appetite and all of that. Please, let's evaluate them for it. And interpreting the TFTs is quite important, because a couple of times, if you want to follow what the labs churn out without taking your time to go through them, you may just not be able to make so much sense out of it. And usually where there's a doubt, it will be fair to always be based on your clinical judgment, and then probably ask for a repeat as well. Usually once the person has started treatment, monitoring of the treatment is also key. One of the things, obviously, is the thionamides have their side effects, like Dr. Rahima did mention. Commonly, you have someone who is on carbimazole and comes in recurrent sore throat and all of that. And then we see, without probably asking for a simple test like a full blood count, just to evaluate for agranulocytosis. Because in as much as we are treating the patient, we need to be extremely careful about the side effects of these medicines as well. So let's please take note of this and help improve upon the management of the patients. Dr. Morgan, any closing remarks that you do have before we draw down the curtains on the presentation?
I think it's been a very good session, and we have learned a lot. So just to reiterate the part about the monitoring. Now, usually when you start them on the medicine, you want to look at their thyroid function levels in about 6 weeks to look at how the direction of the values are going, whether you are making gains or if you need to make adjustments to your medication. And so you don't just give the drug and then go and sleep, but you follow up the person and see whether what you're doing is going fine. I think it's been a very good presentation, and thank you for the platform once again.
Thank you very much, Dr. Harriet Morgan, for joining us in this presentation. Like I call her, she's my endocrinologist professor back in training. Dr. Rahima, great job done. Thank you very much for enlightening us with the presentation on hyperthyroidism. I trust all of us did learn one thing or the other. Kindly join us next week. You'll see the adverts on the various platforms as usual on Thursday, 3 p.m. Ghana time. Thank you very much. Take care of yourselves. Bye-bye.
Bye.